It's a great pleasure to have Mark here. I consider him the guru of healthcare knowledge from running the country's healthcare system, from all the experiences he has had in the past. He is a physician and economist by training. He trained at Harvard and he was a triple threat guy while he was there. He got an MD and was going into internal medicine. He also got a PhD in economics, which he did at MIT, and then simultaneously was going to the Kennedy School and got a master's in public administration. And one of those, you know. And anyway, he went to house staff training after that at the Brigham, and became an intern. He was board qualified in internal medicine. Went to Stanford, where he taught economics and medicine, and actually saw patients. He did that for some period, and migrated for a rather long time to Washington, D.C., where he first worked as some kind of whatever. In the Treasury, in the bowels of the Treasury, and then did economics in the White House, the office of the White House, and then at a very young age was catapulted to be commissioner of the FDA, which he did for a couple of years, and carried out some real innovations which were important for drug review and approval at that time, and trying to really make it easier and more efficient as a pathway. Within 2 years, he was drafted into the running director of the Centers for Medicare and Medicaid Services, which he did for a couple of years also, and introduced a number of innovations there as well for prescription drug coverage and support for getting public-private people together to cooperate and try to improve the system. So what's he been doing? He's been focusing, you can tell us in a minute, but he's been focusing on what's important in health care. How do you measure it? How do you value it? And how do you pay for it? How do you make it better? And it's his whole life. He's been doing it his entire career. He's really focused on that, which boils down to what's happening to the patient and what's it cost to take care of that patient. And to do that by having incentives where they should be. That's what I think he's been doing. And so he was at CMS, Centers for Medicare and Medicaid Services, for a couple of years, and then he went to Brookings. He was quoted as saying he was going to write a book. Did you write a book?
I wrote a couple, but small books.
Okay, small.
Or long articles.
Okay. But he's done a lot of writing. And he was there for quite a while, longer than CMS and the FDA, but recently switched to Duke, a policy center, Margolis Health Policy Center, which he runs. And he has a center there and in Washington, no surprise, because of his policy work, and that's his interest. And all the time focused on improving outcomes for people at the lowest cost. So that's what it's all about. And he's gone there. He is there now as a professor of business, policy and medical science, whatever it is. And he's terrific at what he does, and he knows so much, and he's so innovative in his ideas that I thought he would be a terrific person for us today. And I thank you for being here, Mark. He's going to talk about healthcare policy and reform, tie it up with what's happening in the political scene, and answer any questions you have. Mark.
Thank you. Thank you, Roy. Thanks, Roy, and thanks all of you who are here this afternoon. You know, Roy can do a better job with my bio off the top of his head, both the key details and, more importantly, the intent and the goals than just about anybody I've seen with notes or text that they're reading. It's really impressive, and he does that all the time. What Roy emphasized about the work that we're doing at our new Duke Margolis Center for Health Policy, it's a university-wide institute with a big presence in Washington, D.C., with a founding gift from Bob Margolis, who some of you may know is the former chair of Healthcare Partners. Our mission is really to develop and help implement new policy ideas to improve human health. And it is such a pleasure to be here with Roy and the Galien Foundation, since the missions are just exactly aligned. The Galien Foundation is about biomedical innovation to improve human health, and it's a reflection of all of you who participate in this global effort. We don't get too caught up on the details along the way, the politics, the difficulties of the science. It really is a terrific forum for bringing these ideas together, and not only remembering why we're here, but also working together on practical steps to move forward on the challenges of improving health for the population. And what I want to do is bring these two groups together. Our focus on health policy and reforms in care delivery and where those are heading, with the continuing strong interest and support from the foundation, from all of you in this room, about capitalizing on what I think are more promising opportunities than ever for biomedical science to improve human health. But it does mean changes in the way that I think all of your work is going to go forward. In the past, I think it's been enough for biomedical innovators to focus on the science, to really think about what you need to do in that getting into humans, those trials, pivotal trial to get FDA approval, and then it becomes healthcare delivery. Where I think we're seeing in healthcare is becoming much more of a continuum, where as we learn more about personalized medicine, we talked about that this morning, as we learn more about the growing array of opportunities to treat previously unmet medical needs, there is going to be more of a continuum, and it is something to think about in the strategy for companies and investors bringing products forward. So I want to talk about these fundamentals driving health policy and health reform, and about what I see as some of the most promising opportunities for new directions in policy to support it. As Roy just said, not surprisingly, that's going to mean a big emphasis on value and shifting away from the way we pay for and regulate drugs and other biomedical products based on essentially volume, and towards thinking about how products can work together with other medical innovations to get the best outcomes at the lowest cost for each patient. We may have a little bit of time, or I'll try in my talk to talk about the different kinds of issues for different types of drugs, the health policies and payment systems and regulations relevant to oral drugs and physician-administered drugs and generics, and now in the U.S. already in most of the rest of the world biosimilars, that they present some different policy issues. But I mainly want to focus on these big overall themes in this global shift towards value-based payment in healthcare. I'm going to do it talking mainly from a U.S. perspective, but happy to expand further on what we're seeing around the world. Our program at Duke has a global focus, what we're seeing around the world in steps in the same direction. And I think there are some pretty fundamental implications for pharmaceuticals, with some opportunities now to be part of the leadership for this change, as I know many of you in this room are already thinking about and acting on. So no talk about biomedical innovation should begin or end on anything other than the benefits for patients. And one of the true privileges of being able to work in health policy and health care at this time is to see what all has happened over just my career in terms of improving outcomes for patients. I did my residency, as Roy very carefully documented, in the early 1990s, where when I was an intern, a lot of the patients on our wards were patients with advanced AIDS, where we had basically nothing to do for them except try to keep them comfortable and offer some inadequate treatments for opportunistic infections. By the time I was done with my residency, we were starting to use AZT in patients and trials and then in practice. By the time I was in practice for just a few years, many of my HIV patients were managing their chronic diseases just fine with what seems like close to normal life expectancy on one pill a day. It's truly remarkable transformation. And you think about somebody who's lived through this truly in their career. I was talking with Roy some last night about when he started prior to Merck. And heart disease was basically a condition that you watched and offered some nitroglycerin maybe and hoped for the best. Over the course of his career, with the development of first statins and along with that many other technologies for acute cardiac conditions, for blood pressure, for treating other risk factors, we've seen a 60% reduction in cardiovascular disease mortality. And this is not the only case. Cancer mortality rates, population mortality rates, not just incident, not just diagnosis, survival from diagnosis. Cancer mortality rates have fallen in this country by 20% over the last 20 years. And think about just about all the areas that you all are working in. You can point to examples, important examples that have transformed the lives of millions of patients here in the United States and around the world. But along with that, as you know, it hasn't been easy. I don't know if my collaborators from Jonathan Leff and collaborators from Deerfield Research are still here. This is from a paper that we did together pointing out some of the big challenges that we've seen over the last 20, 30 years in product development. With, so you can see on the chart on your left the rising R&D spending, but over the last couple of decades, not a corresponding increase in drugs reaching patients. And Jonathan likes to talk about the chart on the right, which he terms Eroom's law, or the opposite of Moore's law, where there is something like an exponential reduction that we've seen over the last couple of decades in terms of R&D productivity and for pharmaceuticals, the dollar spent versus the number of new drugs coming out. This has gotten a lot of attention in policy circles, and I think we're living in an era now, since 2010 especially, where there have been notable improvements, both regulatory and legislative, in policies that are intended to make drug development more efficient. I'm not going to go through everything on this list. I'll make the slides available after for those of you who are interested, but regulatory reforms around shifting some questions that can be answered in the post-market setting, especially as we have better data systems in place from pre-market, innovations in clinical trials to try to bring down the exponential growth that we've seen over the last few decades in the cost of clinical trial enrollment and participation, things like master protocols and ongoing trial networks, ways of reaching patients that could benefit from participation much more efficiently, lots of pre-competitive collaborations that are just growing. We're by no means done in these areas, but we're seeing some important progress. And as a result of that, I think you can look at this chart as based on some work that FDA actually reported on and through 2012 on what kinds of drug approvals they're seeing. We actually put in an extension out to 2015. So the number of new drug approvals are way up in the last few years and continuing at a pretty impressive pace this year. And perhaps even more notably, the drugs that are getting approved are much more shift-tilted towards first in class, or what FDA's termed improvements in class, rather than just me too. So drugs that work better side effect profiles, easier to take, and so forth. That's where innovation is increasingly headed, and it's up. And I think if you did an extension of that E-rooms chart that I showed you before, it would be looking better. I mean, it's still costly, it's still uncertain, but this is some notable progress. And on top of that, there's some bipartisan support in the U.S. and some agreement around the world. If you look at policy steps taking place through IMI in Europe, and steps in Asia and such areas as cellular and regenerative therapies, that more can and is being done. The 21st Century Cures legislation, which we've already talked about today, so I'm not going to go into a lot of details again, builds on some of the recent kinds of steps that I've described. Hasn't passed Congress yet. I think there's some hope that it will pass in the lame duck session. I wouldn't hold out too much hope there. Kind of a difficult legislative period, I think, coming in the next month. But there is must-pass legislation on Congress's agenda next year, the next round of the prescription drug and other user fee legislations, which are absolutely integral to FDA and the function of our biomedical innovation enterprise. So that will pass at some point in 2017, and in all likelihood, if the 21st Century Cures doesn't make it through before then, we've seen lots of examples of this bipartisan legislation in the past being a vehicle for other improvements in regulation. So the kinds of things in 21st Century Cures, these other steps in the prescription drug user fees, which include more steps like more reliance on biomarkers, more steps to encourage individual patient voices and patient-driven outcomes assessments and in regulation, more use of real-world evidence. All of that is coming, and I think all of that is to the good for the productivity of the biomedical research enterprise. With all of this progress, and with more coming, with these policy reforms I've just described, though, has been an increasingly central challenge in biomedical innovation. Costs are going up. Now, part of this is due to demographics, with more people living longer in no small part due to this innovation. That's just more spending on health care that goes along with it. But I do want to make an important point about these technologies. It is true that new biomedical cures, new treatments, have some downstream effects in reducing other healthcare costs, and that's worth a lot. If you don't have subsequent complications that lead to hospitalizations, if you've got hepatitis C and get that cured, that means less cost down the road for liver failure and the complications of cirrhosis and transplant and the like. But that is not the main reason that we are interested in innovation, and it's not the main thing that people value, right? Avoiding healthcare costs is good, but what people really value is longer and better lives for themselves and their loved ones. In fact, economists who have looked at the productivity of the different sectors of our economy, healthcare, transportation, IT, have generally come to the conclusion that the most productive sector of the U.S. and global economies over the last 50 years has been healthcare, of all things. Not because we're spending less money over time, we're spending a lot more, but because, you know, it's great to have iPads, it's great to have jet travel, I guess it's great to have 500 cable stations, but what people really enjoy is the time to use all those kinds of services, or just to enjoy a sunset, or just to have their mom around longer, that could not have happened before, better quality of life. That is really worth a lot, and that is the main reason that healthcare costs have been going up, and it is also a reason that the American public and people around the world have put considerable stock in supporting biomedical innovation despite the increases in costs that we've seen. This is a chart showing the three things that the U.S. government spends money on, and it goes in terms of percentage of GDP on the vertical axis from the mid-70s up through 2040. The bottom part, the blue section,
section is Social Security. That's gone from about 4% of GDP. We're talking about, $16, $18 trillion economy. So this is real money, 4% of GDP. With the retirement of the baby boom, that's going up to about 5%. And this has been in the news lately with many groups trying to get the candidates to comment on what they're going to do about sustaining Social Security. It's a big deal, 1% of GDP. But you can see the big story over the last 40 years, along with those substantial improvements in health outcomes that I described, has been healthcare costs. The red section, Medicare, Medicaid, and now the subsidies for health insurance under the Affordable Care Act have gone from about 1% of GDP to around 5% of GDP, and on course to be 8% or more of GDP by 15 to 20 years from now. And I should say these are conservative assumptions, most experts think, from the nonpartisan Congressional Budget Office, based on some projections in current law that may end up not being quite so sustainable based on our historical past. The gray area is everything else that the federal government spends money on. You can see that big blip up in 2008 as the federal government's response to the Great Recession. But you can see that the overall trend in that gray area has been declining. So this is everything else. This is spending on education. This is spending on social services. It's spending on infrastructure. It's spending on national defense and homeland security. By the way, national defense, homeland security together, maybe $600 billion. Less than 60% of the current run rate of the programs overseen by my old agency, CMS, which is well over $1 trillion now, federal and state contributions. So you can see that what has happened consistently over time is as the American public has guided Congress and our political leaders, so what our national spending priorities should be, healthcare has consistently won for 40 years. Now, this is built into the federal budget now, so-called sequestration, which is operative now with bipartisan support, builds in increasing Medicare costs, pretty much in line, a little bit of tightening, but pretty much in line with our existing long-term program commitments and design. Medicaid as well, ACA, the new entitlements there, and everything else that gets squeezed, the so-called discretionary part of the budget, has been going down in real terms. And that is the point I want to make is that compared to the 1970s, 1980s, even 1990s, when biomedical innovation may have been more primarily about biomedical innovation today is about macroeconomics and the overall capacity of our country to prioritize and support the important national priorities for the U.S. population. Another way of looking at this is a look at total spending in different countries on health care and social services. The red circle in the middle is the United States. Blue on the chart is health care spending, total, public and private. Red on the chart is social service spending, total, public and private. So that includes things like education, assistance for low-income families, housing support, things like that. And you can see the U.S. is not an outlier in terms of these total expenditures on activities that probably do have an important impact on population health. I'll get to that more in a second. We just differ in the distribution. It's much more shifted towards healthcare and much less shifted towards these other programs that can potentially have an impact on the lives of Americans. Another way of looking at this is from a personal standpoint. This is what individual households in the middle class. I'm not talking about low income, not talking about higher income Americans, but think $50 to $125 or so thousand dollars. What's happened to their budgets over the last 7 years? So this is a group that through about 2014 was not seeing any increases in take-home wages, not because their productivity or compensation wasn't going up, at least since the recession, but because it was more or less completely eaten up by increased benefit costs and their increased payments for health care services. So that's what's been rising there, not housing, food, other types of essentials. And if you think about the big picture here, this is drawing on some work that's been involved with the National Academy in medicine. The chart itself is kind of old. We think about why people aren't living as long as they could. This is about premature death. What are the big contributions to premature death? You can see healthcare is up there. I'm not sure if I've got a pointer here, but healthcare is that kind of tan area that says 10%. I think that 10%, that was in early 2000s. I think that's low today. You can see the other bigger areas are genetic predisposition, so that's becoming more of a healthcare treatable area with some of the gene therapies and other treatments that we've heard about some today. You're going to be part of a really interesting panel after this talk. Behavior, so the right side of the chart blows up the behavioral cause of death. It is still by far number one is smoking. But also obesity, inactivity, drug-induced, alcohol-induced premature deaths for some segments of the population are actually going up, not down. That's still where all the action is. So in some sense, and this is the challenge I want to put on the table today, we're winning the battles in terms of biomedical innovation and technology, improving lives, lengthening them, improving quality of life. But the overall war in terms of premature death, if you think about some of the things that could really have an impact on this chart, best long-term predictor of how much money you're going to make and how long you're going to live is not the medical spending that you have on your behalf, it's your education. Best long-term predictors are much more related to social and environmental exposures. Environmental exposures in early childhood, now getting more and more compelling evidence, have a big impact, not just on risk of conditions like suicide and violent death, but conditions like cancer and diabetes and cardiovascular disease. And we're spending more on the health care, but as I showed you in the previous charts, it is getting tougher and tougher to find the resources and to put into the public priority spending on other things that can really impact population health. Consequence of that may be these couple of charts. These are going to be hard to read, but this is from some studies published in JAMA earlier this year by some of my former colleagues from Stanford, tracking improvements in life expectancy by income group. So divided the country basically, or the population, into 20 different income groups, the lowest fifth, the lowest 5%, all the way up to the highest 5%. The main point of the charts, what you want to see over this 15-year period they studied from around 2000 to 2014 is increases. So higher is better. You can see on I'm focusing on the bottom two charts now for men and for women, some significant improvements in life expectancy, but very strongly related to income and probably to ability to influence those other factors, the environmental factors, the access to education, and so forth. So if you look at the bottom chart, that's the annual rate of increase for the top 10% of the U.S. population. Congratulations. It's an increase in life expectancy of about 3 years. If you make it to age 40, 3 years, you're living 3 years longer in 2015 as you were in 2000. Congratulations. That puts you in probably about the top life expectancy category in the world. But it's very different as you go further down the income distribution, with the lowest income decile seeing basically no improvements in mortality in the last 15 years, despite all the biomedical progress, despite the increased spending on Medicaid and low-income assistance programs with the ACA and other healthcare-related initiatives. So we're not there yet, and I am concerned that if we stay on the current trajectory, we're not going to get there. So put on top of that what the American public is seeing in terms of increased spending on drugs. Now, I've talked about overall increases in healthcare spending, and that's going up, and it's definitely not mainly drugs. But it has been a notable few years in terms of drug spending. So this has spending for private health insurance, Medicare, and Medicaid on drugs by year. And you can see that 2013, 2014, 2015 were a pretty remarkable period, and that, again, propelled drug spending into the front of the public consciousness. And it's not just drugs. As we've been showing on the previous chart, the fundamental here is innovation that's leading to higher healthcare costs, costs along with better outcomes. And drug innovation, biopharmaceutical innovation, is a central part of that. That, by the way, that those projected spending of the last few years, which was first and foremost a factor in that was the new hepatitis C cures. That's projected to go back down, but as you can see, the rates of spending growth with continued biomedical innovation that's coming is still running significantly higher than the rate of growth of the economy. And if you look at the breakdown of this, and this is based on data from IMS, a number of contributors. So if the gray line across the middle is zero spending, within drug spending growth, there are different contributors to both increases and decreases. The big negative in all of these charts, the orange, is shifts from brands to generics. One of the things that Medicare Part D and the rest of the market following along with it has accomplished over the last decade is when generic drugs become available with the kind of benefit designs that people are facing, where they save a lot of money if they switch from a brand to a generic, they do it. So that's been a big contributor to the slower spending growth that we saw in prescription drugs from, say, 2009 through 2012. Since then, with fewer patent cliffs and more innovation. So I showed you the FDA approval chart, and more innovation, that number's become relatively more positive. Notable in here, it's not just the new brands coming on, that's the dark blue. It's also price increases for the existing brand name drugs, and that's something that, as you've heard, is getting a lot of policy attention in Washington. Price increases for drugs. Would add that for generics, this chart shows 2010 versus 2014 prescriptions, which you can see are overwhelmingly generic. We're up to about 88% of prescriptions in the U.S. being for generic drugs. That's almost topped out. And will, again, might go lower if we get more new drugs on the market. Most of the spending, of course, is on the brand name drugs, and despite a few outliers in generic pricing that we've heard about that make the headlines, overall, generic drug prices are staying pretty low and lower rates of increase than brand name prices. I know there's been some discussion about how brand name prices are switching more into higher lists and bigger rebates being given, or coupons or things like that. But even accounting for that, there's still significant growth in prices beyond inflation for existing drugs. So that's the kind of environment that we're facing. And what I want to spend the rest of the time talking about is, you can see why this is a front burner issue and is not going to go away from a political standpoint. What I want to talk about for the rest of the time is ways in which we might do better in terms of both providing access, affordable access to medical treatments, and enabling people to also have resources left over for the other things, the education, the early childhood support, making their own environment and housing better, that are also really important for their health and for the overall health of the population. Ways to provide more resources, preserve more resources for that, while at the same time encouraging biomedical innovation, so getting both access and incentives. I have to say that, as hopefully the previous charts made clear, this is now a macroeconomic level problem, and failing to identify more effective ways to provide both access and continued innovation, so you're going to see continued pressure on trying to bring those prices down. You can see why that's, you can see based on these charts why that's such an important policy issue right now. And I think the best way to start this is start at this other direction in health policy, which does have some bipartisan support, is to introduce or remind you about some of the opportunities for getting higher value in healthcare overall. So healthcare is mainly not pharmaceuticals, but most of the opportunities to improve value in overall healthcare, to avoid unnecessary costs, do involve pharmaceuticals in one way or another. For example, many patients who are being treated for cancer or other serious conditions often get those treatments in the hospital, where costs costs can be 30 to 40% higher than more community-based oncology practices or for other conditions, outpatient surgery and the like. In other sectors of our economy, we're seeing a shift away from traditional brick-and-mortar institutions towards more convenient and lower-cost locations of care. That involves pharmaceuticals, since the more that pharmaceuticals can be used in these less costly settings, the lower overall cost will be. Many of the conditions treated by by important pharmaceuticals are chronic diseases where team-based approaches to care are probably better than relying on a traditional physician visit-focused approach. Many innovative programs for managing diabetes involve relying more on nurse practitioners or pharmacists or even social workers who can really figure out why a patient's not adhering to their medication and do something about it in a way that's very hard to do in a traditional approach to care. There are obviously a lot of opportunities with pharmaceuticals to avoid emergency department visits, hospitalizations, other preventable complications, but also a lot of opportunities probably to target the costly pharmaceuticals to the patients who will most benefit, both based on predictive and precision medicine and based on just listening to patients if they've got an advanced illness about the kind of care that they'd like to have at the end of life. And not to mention a lot of opportunities in healthcare. A lot of healthcare costs are driven by social factors, behavioral factors that we can find ways to address them directly could help keep healthcare costs down. The challenge with all of these is that our traditional healthcare financing systems really don't support it. I mean, we have good mechanisms for paying for new drugs. We can argue about whether the exact prices are as high as they should be or not. But most of these things on this chart don't get paid for at all. One of my first meetings as a CMS administrator was with the CEOs of a number of physician group practices around the country who are trying to do a lot of things on this list. Answer their patients' emails, hire a nurse practitioner or a social worker to track their patients with chronic diseases and make sure they were adhering, spend extra time doing care plans with patients, especially higher risk patients, to keep them out of the hospital or the doctor's office. And the reason they came to me was they were brought in data showing that they were actually getting better outcomes for their patients and lower costs for the Medicare program, but these were not sustainable approaches because Medicare didn't pay for any of those things that I just mentioned, none of them. So that's what's led to a big push in the rest of healthcare outside of pharmaceuticals for more emphasis on value. And one of the activities that we support at Duke is a national public-private collaboration funded mainly by CMS, but involving a lot of healthcare provider groups and major private payers and states, called Healthcare Payment Learning and Action Network, that is trying to facilitate more movement in our healthcare payment systems away from fee-for-service. That's what's category 1 on this chart, away even from fee-for-service payments that have a little bit of an up or down adjustment based on some measure of quality of care, and into what's listed as category 3 and 4 on this chart, so-called alternative payment models, which is not a great term because it doesn't really tell you what it is. It just tells you what it's not. It's not traditional fee-for-service. What is it? Well, it's payment that's linked not to which specific services a patient received, but payments linked to the overall care quality and results for patients. So many of these are at the episode level, and you've probably heard about the new Medicare bundled episode payments for conditions like joint replacement and hip fracture or heart attacks. Many of them are at more of the whole patient level, so-called accountable care organizations. That's what we ended up doing with those physician group practices who came in to visit me back in 2004. We set up a forerunner of the ACO program called the Physician Group Practice Demonstration, where there's now we didn't get completely rid of fee-for-service payments. We set up a second payment track that was based on tracking how well the organizations were doing in terms of keeping overall costs down, not just physician services, but overall costs down, and getting improvements in things like diabetes control or blood pressure control or patient experience with care. and the deal was that they could improve on those measures, quality and total spending. They got to keep a lot of the savings. Well, the models that we're starting to see today are moving farther away from that, putting less weight, less dollars in the fee-for-service track and more in these episode or person-level approaches to payment. One example of this in oncology is CMS's recently implemented oncology care model. The idea here is to not just pay oncologists on the basis of visits and time they and attending on their patients in the hospital or administering chemotherapy, but having a per member per month payment basically for patients who are undergoing active treatment that delinks the way that the oncologists are paid from the traditional services, the ones that have been reimbursed, giving them more flexibility to invest in things like extended office hours or nurse practitioners to help with care planning or after-hours responses to head off patients who might otherwise head to the emergency room. United Healthcare, Anthem, other private insurers have implemented programs like this that delinked in part the way that oncologists were paid from the volume and intensity of drugs that they administered, and they found, in short, not that much savings on the drug side directly, but big savings overall, because it turns out there are a lot of opportunities for cancer patients to be treated in the office, and a lot of opportunities to head off complications that in the absence of care coordination and support for these approaches to care would lead to higher health care costs. And so CMS, Secretary Burwell, I was at our Healthcare Payment Learning and Action Network Summit earlier this week, where she reaffirmed the CMS commitment to moving a larger share of payments into these new models. The dark blue here is those alternative payment models based on value, the episode type payments, the whole person type payments, as opposed to fee for service, aiming for, they've already achieved 30% this year, aiming for 50% by 2018, and this is also a approach that's being shared in the private sector and in state Medicaid plans, with a growing number of patients nationwide being treated in accountable care organizations, where at least some, an increasing amount of the payment, is not related to specific traditional healthcare services, but towards support that the providers are on the hook for they're on the hook financially for this. They don't get there's an NPR story where the providers were talking about how they wanted to be careful with the pot, that it's not an unlimited amount of funding, but it does give them more of an ability to shift resources into what really matters for patients. So we are seeing a lot of this happen for doctors, for hospitals. This was behind the bipartisan macro legislation that passed Congress last year to reform physician payments. Who says there's not bipartisanship in healthcare? These kind of shift towards value-based payment, absolutely there. Doctors, hospitals, post-acute care facilities, where this really hasn't come yet is in drugs. And it's kind of ironic, because if you think about drugs, these are treatments that take an awful lot of upfront investment. The cost of each pill is pretty low, and what really matters is targeting it, using it effectively in the right patients. But so far, not big parts of a lot of these payment reforms. I think that's starting to change. I'll give you a few examples of payments that are more value-based, based on prior evidence and patient results, and then steps to build on value-based insurance design. So it's not like there isn't value-based payment at all. Every insurer would tell you that their whole formulary design with tiers is based on value. But even within that, and including for physician-administered drugs that generally aren't subject to the same kind of formulary prioritization, there's a lot of evidence of substantial variation in the apparent drug value across different indications. So one response to this is PBMs and payers moving to implement contracts that are more indication-based. So it's a step in this direction of paying a step further in the direction of paying more for value based on particular types of patients. Challenges with this are that it can be hard to build into a contract, especially as you get to more personalized medicine, all the things that might matter for whether a drug really is the right choice for a particular patient. It doesn't work well with the combination therapies that are going to be increasingly important, not just for cancer, but for many other conditions, rheumatoid arthritis and the like. And so there has been some initial interest, especially outside the U.S., but in the U.S. as well, in payments that, like those value-based payment reforms I was describing for health care providers, involve at least partly a focus on results. So here Merck has been doing some leading work with its diabetes treatments, where the rebates are based not on the volume of drugs sold, at least not only on the volume of drugs sold, but based on patient adherence to medications. For drugs like Entresto, a new heart failure treatment shown to be very efficacious in clinical trials. The Novartis contracts with some of the payers are linking the rebate to whether or not heart failure patients really do subsequently experience better outcomes, as measured by fewer hospitalizations with complications. And there's a longer list that I could put up on this chart. Treatments for osteoporosis, treatments for rheumatoid arthritis. Not yet widespread in the U.S., but coming. There are a number of obstacles to implementing these reforms. One of the big initiatives that we're undertaking, I'm going to announce this officially with the formal launch of our center at Duke, is a collaboration around finding ways past some of the practical obstacles here. A lot of things on this list, like the so-called Medicaid best price regulations, anti-kickback regulations, are designed, they're there for a good reason in federal payment programs, but they're designed for fee-for-service payment systems, right, where once a drug reaches the market, the concern is that there'd be an incentive for the manufacturer to try to have it used as much as possible, since that's the revenue model. Under these at-risk models, it's different. Manufacturer gets paid more, just like a hospital or a physician under the new payment models might get paid more for better results and lower costs. And there you really want to encourage collaboration across the different parties. They're aligned financially, and these fee-for-service regulations don't work as well. But we haven't quite figured out how to get past them. Same thing for FDA off-label communication. I would say that in all these areas, there's a lot of interest from CMS, a lot of interest from private payers and FDA in trying to work this out, but it is going to take some additional work. But as I emphasize as well, very importantly, is not just about the way that we pay for drugs, about the way that we pay providers, and the way that we pay drug manufacturers. It's also about engaging patients or consumers. The reason I think that Medicare Part D has remained as popular as it has, and has, despite a large wave of biomedical innovation, has been able to keep spending growth relatively low, is that it really tries to encourage patients directly. So it's not that the doctor gets a little bit more of a payment if they switch a patient to a generic, as the patient gets to pay much less out of pocket compared to a traditional insurance design. If you switch from a brand to a generic, your payment might go from $90 or $100 a month to $2. It's much more than you get in a traditional 20% copay insurance design. That's a big driver of what we've seen in drug spending so far. The final thing I'd like to end on is think about ways, not just in which drugs by themselves could be paid more on a value basis, but ways in which pharmaceutical product developers could be better aligned with what is happening in our healthcare system. The contracts the programs that Medicare and private payers are putting in place have also created some opportunities for different kinds of providers to work together. So in an episode payment model, say for cancer care, like I talked about before, CMS and private payers make it possible for the oncology practice to form new contracts with post-acute care providers, with other specialists, where they can share in this risk and share in the upside from working together to get better outcomes at a lower cost. So far, that approach has not been extended to drug manufacturers, but there is a precedent, and again, this is a topic that we're working on further right now. So you can envision a future of payment, and this is coming. The parts at the top of this chart, payments for primary care that are less tied to the number of visits that you make to an office, and more tied towards a per member per month payment to a primary care provider for coordinating overall care. Specialty care payments that are more about focusing on the episode of care or the overall needs for a patient rather than specific services. ACO and population accountability payments are about getting total cost of care down and outcomes improved for an overall population. That all is happening. And the real question is where does the bottom part fit in? And I've given you some hints at least about where that could head, though I think we're not there. We're definitely not there yet. And this is an area where decisions by companies, changes in policy to facilitate new payment models for drugs are really going to be important. And the last thing I'd like to leave on is that this is definitely not easy. This chart that looks like a complete scatter shot is a summary of the results of the Medicare ACOs through 2015. So on the horizontal axis is the measures of quality that are how they're doing in terms of the measures of quality that are incorporated in these new payment models and in the ACO model. And you can see that there's a concentration of the dots over to the right of the chart. That's good. And I'm saying that you pay more for align payments better with population health outcomes and patient experience, you tend to get better performance, at least on those in those areas of that are measured. Where there's a completely kind of random distribution is on the vertical axis, and that's savings relative to benchmarks. Where you'd like to be on this chart is the top right. That is not where most healthcare organizations are today. This is hard. So we're implementing new payment models, but this is not an easy path. It's not an easy journey, either for designing the payment models the right way, or, as this chart emphasizes, for healthcare organizations figuring out how to succeed. There are more efforts underway now to try to provide data and infrastructure and analytic support for the physician groups, the hospitals, the integrated systems that are trying to do better in these models, but we still have a ways to go. And this is where, again, I think pharmaceutical product developers who know a lot, probably know more than anybody else about which patients are going to benefit, what safety profiles are, what potential benefits are, could really help with improving the way that care is delivered. But we certainly need better evidence. We're not done with any of this, and we certainly need better evidence, need further steps on implementing reforms. And I think we're right in the middle of kind of the early stages of a lot of these payment reforms being implemented. And the real question is not whether or not we're going to continue going down this road. I showed you the fundamentals at the beginning. The pressures on cost and the opportunities for biomedical innovation are both increasing in intensity, not decreasing. We're going to go down this road. The question is just how quickly and how effectively and how much are we really going to achieve better outcomes for patients through both better access to care, affordable access to care, and truly effective biomedical innovation. Thank you all very much for the opportunity to join you this afternoon.
Thank you, Mark. Thank you, Mark. I think we're all together on improving health, making everybody more efficient. I think everyone in this room probably feels that the most critical thing for us as an industry is that we don't lose innovation, don't lose incentive for innovation, and because that would kill the goose, and that's what it's all about. I think pharmaceutical prices, and especially cancer drugs, have done strange things. Now, by the way, when I talk about pricing, I'm not referring to the crazy pricing that has occurred in a couple of companies where they've taken a niche drug and increased the price by 50 times. And that's crazy. But I mean normal pricing, which is almost crazy, and because it's too high. And the way I look at it, some early drugs that were innovative at the time, but were not very good, came out at $50,000 for a course of treatment. And therefore, when a really good drug came along, it had to be a multiple of that. I think that's where it all started. And so we that popped up to 100 or 150, and now 200,000. But today, in the meetings, of course, the meetings we heard today, is that the way we're going to have to be at combinations, because there's a possibility for cures. For the first time, we're talking about cancer cures, and we don't want to step away from that. So if you take something that costs $100,000, and you need 3 of them, it's pretty hard to take. And so those are the things that have to be balanced. And it's again, and Mark really hit it right on the head, we've got to get the value based on the value to the patient, and be fair, be seen as a fair price for that value, because they love the impact on them and their families, but they don't want to get skinned. They want to feel good about it. And that's where we have to drive to, and that's why these new models, I think, are very important. So let me open the program right here, please. Can we have a microphone to the questions?
Thank you. Fred Frank. Mark, one of the things you didn't address, which I think is going to be very important in the future, is the impact on this of getting young people to go into the practice of medicine.
Yeah.
And we're hearing from a lot of the leading medical schools that this is becoming a very big issue of attracting the best and the brightest into becoming doctors. What is the implication of these programs on that?
Yeah, the medical practice today is very frustrating, especially for people who have seen what it used to be like when there were less restrictions on what you can do, less paperwork, less price regulation. What I think the biggest reason for optimism is that if you look at provider satisfaction in some of the new payment models I was describing, it's really good. So I'll give you one example. Some of the accountable care organizations that exist today are led by primary care groups. So they're just maybe a group of 7, 8, 10 doctors taking on this accountability, not just for seeing patients during their scheduled office visits and sending the bill for it, but for actually getting higher patient experience measures and controlling diabetes and other chronic diseases better. The ones who have moved the farthest away from fee-for-service seem and done it successfully seem to be much happier than people in traditional practice. Why? They are in these models, so-called direct billing models, or it's basically capitated primary care with some accountability for overall cost. You don't have to fill out quite so much paperwork. You do have to report on some measures of quality of care, since that matters for payment. But it's the stuff that you kind of want to track anyway, like how well controlled your patients with diabetes are doing. And you don't have to report under the new CMS rules on all the so-called MIPS measures, all the kind of micromanagement of care. You do have to be comfortable with recognizing that a non-trivial part of your income is going to depend on how well your patients are doing overall. So you do have to have some data analytics, some capacity to look at the bigger picture. But primary care physicians in some of those practices are making 50, 80% more than traditional primary care doctors, because they're finding more efficient ways to deliver care overall, and you don't have to prevent that many hospitalizations to really increase your practice revenues under this kind of model. And they get to focus more on their payments are more aligned with what they really want to do for their patients. I have to tell you, though, that's kind of an ideal state. It's not the way that most physicians are experiencing payment reform today. They're dealing with all the paperwork from the old models and the fee-for-service controls and regulations, and a lot of difficulties in standing up and reporting in these new models. But I can say, just like I said at the outset, that staying with fee-for-service is not the future for medicine. And one of the things that we're trying to do with our program at Duke is reform the way physician education works, so that there's a higher, not just awareness, but comfort level around things like accountability and support for what happens to your patients
after they leave your office and for addressing some of their underlying concerns. I think we're not there yet, but I think for the longer term, that can really make for much higher professional satisfaction. And that's why we all got into this in the first place, right? Is have the biggest impact possible on the lives of our patients. Wish it was easier.
Yes, and not all medical schools are seeing that, Fred. At Columbia, the number of students applying is higher, and the applicants are of higher quality. And so the students coming in are terrific, and they're greatly motivated to do the right things.
But they need a different kind of education than what we've done traditionally.
It's new. Yes.
Jay Siegel, J&J. So some new technologies, regenerative medicine, gene therapy, offer the possibility of cures for chronic disease, not just cancer, but chronic diseases. And one of the real challenges of our reimbursement system is even if a value-based payment for a cure, if it's a one-time or short course therapy, may mean a lot of money up front, saving far more in the distance.
Yeah.
Arguably, that's the case with hepatitis C, and yet, since people switch insurers from year to year, the payer doesn't reap those distant benefits, and there's a lot of pushback. Do you have ideas for, and that's creating some concern about, are there incentives to develop cures, which is something even ones that are value creating and cost savings? Do you have ideas for how to deal with that in a reimbursement? Yeah,
I know they've got all the answers, but you're right that we're hopefully going to be seeing more treatments that are curative or at least hold a strong promise of cures for patients and moving away from these chronic disease type models. And we do need payment models that work with that. I think some of the promising directions here really do involve tying payments directly to outcomes. We're getting there, and we're not there yet, but for some of the gene therapies, there is some heterogeneity in patient responses, how much uptake of the splice gene there is, and resulting impacts, say, on for thalassemia patients on the better hemoglobin variants. So that does lend itself to these kind of results-based payment models. And one of the things that could go along with that is more reliance on tracking data for individual patients over time, even across payers. So this is where I think CMS and other payers are actually interested in a different way of paying. Maybe it's not all upfront payment right at the beginning. Maybe it's a significant payment in year one, a follow-on payment in year two, year three, as long as the patient has outcomes that reflect how well they're doing. And that is a change, and it would require going across multiple payers. But we have payment systems or underlying payment rules now that go across, CPT codes, ICD-9, they go across all the payers. So it's not going to be an easy transition, but it's one that I think we need to start taking on right now, so that we're ready as these treatments come. I think sticking with the traditional fee-for-service type model is going to be really tough for gene therapies.
Okay. Yes, right here. Can we have a microphone? Okay.
Yeah, this is a terrific talk and overview you just gave. I wonder, given your terrific insight, whether you could answer a somewhat granular question. The JAMA papers linking expected life expectancy at age 40 to income showed something that was peculiar and really not explained by the authors. A geographic difference between New York and San Francisco versus Detroit and Dallas, if I recall, where at the lower end of income, there was much better life expectancy in New York and San Francisco. Any idea?
Yeah, it's really something. So just to amplify on that, the authors went a little further than those national statistics that I showed, and they showed trends and differences by income group across different communities, and found some very different patterns. In some areas, San Francisco and the like, not nearly so pronounced differences as the average. In other regions, much larger. And they started to do a look at what the explanatory factors were. before, not a surprising insight probably, it's not just or mainly health insurance coverage. It seems to be other things about the community, like resources available and stresses, exposures, other of those kind of social service type supports that I was highlighting in my talk. But I would say that our understanding of those community factors is really at an early stage. So they did not have any specific recommendations coming out of that, except I guess the hopeful side of this is that that's not destiny, that you don't have to have these big differentials in life expectancy. They don't necessarily have to get bigger, but they're probably not going to get smaller unless we pay a lot more attention to understanding where they're coming from and effective ways to address them.
Just a quick follow-on to that. The sense of the question was, if we really had insight to those differences, could we emulate those in some way and really be
I think that's right. One of the promising things I've seen is in some of these new payment models, especially for Medicaid populations or even in states that haven't expanded Medicaid for their uncompensated care support, many of these areas are moving away from just paying for the hospital admissions and trying to integrate funding streams for social services with healthcare services, so that if a patient with a behavioral health problem, mental health problem, substance abuse problem is repeatedly showing up at the emergency room, they can shift more resources into treatment for that patient, leading to lower costs. Or if a patient's showing up because of housing problems, or a patient with COPD or asthma is having repeated flares because of conditions at home, it's easier to shift resources for those individuals into the non-medical spending that would make a difference. And places like Oregon, Alabama is implementing these regional care organizations that are really about combining social service and medical streams and shifting the resources around to get better outcomes at a lower cost. So it's a start at trying to address that very important challenge.
Yes. Now we'll give you another chance at it.
Dr. McClellan, could you tell us what your thoughts are on how to fix Obamacare?
So good question. So first of all, we got
Obamacare, not the Accountable Care.
Yeah, first of all, we got to get past this election, which fortunately be over in just a couple more weeks. There's the technical fixes and the political fixes, and talk a little bit about both because they're related. I don't think the reason the law is having trouble is only because Republicans are complaining about it. If you look at the design, it's done a pretty good job of attracting and getting people in the insurance pool if they have lower incomes. So think of people below about 250% of the poverty line. They get a lot of help with premiums. They also get help with their out-of-pocket costs. And you look at enrollment rates, they're pretty high in that population group, 70, 80% of the eligible individuals. The way the program was designed, though, those subsidies, especially for out-of-pocket payments, go down pretty steadily after about family income, family of four, about $70,000 or so. So for many people in the middle class, they're looking at the benefits they get versus the cost they have to pay versus the penalty for not enrolling, and they're concluding that it's just not worth it. So the participation rates, as you go up the income distribution, and I'm not talking about really high income people, I'm talking about the middle class, get much lower, and it's that group that is not happy with the way that the program is working. So how could it work? Well, you could put more money into it. Secretary Clinton has proposed expanding the subsidies for the middle class. I doubt that Republicans are going to want to go along with that, and so that means more hard work on figuring out how to do the coverage more efficiently. And if the Republicans get a chance to actually replace or modify the law, I think they'd like to see more flexibility in benefit design, maybe more ways of encouraging the kinds of emphasis on engaging patients access or supporting new models of care that I talked about earlier. But that's not going to be very easy to do politically and not necessarily easy to do right. I think if there is an opportunity for bipartisan compromise on this, which is probably what it's going to take, given the current projections, it doesn't look like one side is going to be in control of everything. Bipartisan compromise might mean for Republicans maybe more innovation at the state level in how they're dealing with kind of the low-income assistance programs. I showed you earlier, well, I didn't show you a chart on it specifically, but number one item in state budgets is Medicaid and health care for their employees and retirees. And there's some states that are doing some really interesting things in terms of redesigning programs, as I mentioned, combining with social services in new ways. So I think maybe there's a bipartisan deal around giving more flexibility to states and accountability for trying out these new approaches to keep overall costs down. Maybe steps that could lower the cost per person in the exchanges in return for a change in the subsidy structure and some help with reinsurance payments and the like. But it's not so simple as just if we had more reinsurance payments, this would work. It's any more significant changes needed than that. And we'll see what happens after the election. Unfortunately, I think this could go on for a bit longer. The law is just not that popular, and while some states are having some real problems with their exchanges, in some states it's doing fine, and others kind of limping along, and it may take another election before we get this completely resolved. I hope not, but maybe.
One last question, because we have run out of time. If there is there a last question? I don't see one, so I want to thank everyone here.
Thank you all very much.
Mark, were terrific. Terrific. Thank you.